Hello, my name is John Buscombe, and I have been asked to record this lecture, which I first gave at Singapore Update 2023. The Singapore Society of Nuclear Medicine has kindly let me record this. The Nuclear Medicine Update occurs normally every 2 years and is a very good teaching resource, so highly recommend to you. So I was asked to give this talk at their annual dinner, and hopefully it should come up soon. And it's really about theragnostics. Now, for many of you, this may seem to be quite new, but for many of us, we've been involved in theragnostics for a considerable period of time. So I'm just trying to get the slideshow to come up, which is just proving to be a little difficult. There we go. So first of all, I'd just like to give my disclosures. So I've done some consultancy work for AAA, Novartis, and for the National Institute of Healthcare and Excellence in the UK, and lectures for ISE Pharmaceuticals, Bristol Scientific, and for Bayer. Some of these areas have been discussed, but I'm not promoting any particular product on this talk. So we're going to talk a little bit about the origins of theragnostics, and then we're going to talk about some agents, specifically MIBG, then PRRT, PSMA, and then some of the challenges and opportunities that theragnostics provides. So to go back to the very beginning, the story is really 86 years old. In 1936, Dr. Saul Hertz had the idea of using radioactive iodine to investigate the thyroid. As you know, iodine is involved in thyroxine. And he talked to a physicist called Carl Compton, who we may know of the Compton Edge fame. And he was able to provide a small amount of what was then iodine-128 for work in rabbits. Eventually, Hertz managed to secure funding from New York's Markle Foundation, and they built a cyclotron at the Massachusetts Institutes of Technology. Saul Hertz himself worked in Boston. They were able to make a mixture of iodine-130 and iodine-131. And in 1941, the first patient with thyroid cancer was given iodine-131. So that's really the start of radionuclide therapy. But also he wanted to look at uptake, particularly in patients with thyrotoxicosis. And for that, he would use smaller activities of iodine-130 and 131. And with his colleagues, he built a machine to enable them to detect the radioactivity and to measure it. This is the machine now. His secretary is sitting on the chair, but actually there's a deliberate mistake. In fact, the chair should actually be facing the other way, i.e. the patient should be facing the wall, because the detector is on that side. But I gather that having had her hair done that day, the secretary insisted that she sat the right way round. And this was then used to determine the amount of iodine-130 or 131 that could be given for treatment. So the very start of a sort of dosimetric approach without actually measuring dose. In 1942, Saul Hertz presented the results of his first 29 patients to his funders in New York, but he couldn't himself do no further work because he was called up into the US Navy. This is in the middle of the Second World War. Whilst he was serving his country in first the Navy and the Marine Corps, Dr. Chapmans and Evans from radiology at Massachusetts General Hospital basically stole his work and passed it off as their own. Some people say this is where the enmity between nuclear medicine and radiology started. I couldn't possibly comment, of course. But Saul Hertz was undeterred. He returned from his war service, and he continued to work with radioiodine. And this was reported in local press. And this is a couple of the newspaper cuttings that are held by his daughter, Barbara Hertz, who runs the Saul Hertz archives. And he concentrated particularly on the treatment of thyroid cancer. And his work became known primarily actually through newspapers. Then, unfortunately, very young, aged 45 in 1950, Solherz died of a heart attack, but his work continued. However, there was very little further progress, almost 40 years after this. And whilst iodine 131 became a standard treatment for both benign and malignant thyroid disease, very few new theragnostic agents became available. Some people use P32 for treatment of polycythemia rubra vera or in painful bone metastasis. And there was some laboratory work labeling particularly antibodies for research. But nuclear medicine concentrated primarily on imaging. Then in the 1980s, things started to change. Bone scintigraphy was paired with strontium-89 to treat painful bone metastasis. And over at the University of Michigan, they explored the use of meta-iodobenziguanidine in pheochromocytomas. So let's talk a little bit about bone metastasis first. Well, we're used to doing bone scintigraphies. For that, we use a technetium diphosphonate, either MDP or HDP. And we know that uptake is related to increased bone turnover, which we see in sclerotic metastasis, recent trauma, degenerative change, and about 100 other causes. It's excreted via the kidneys and bladder. And very soon after the mid-1980s, people started to use different radionuclides for the palliation of pain, which included P32, strontium-89, SMER153, EDTMP, rhenium-186, and rhenium-188, and more recently, lutetium-177 HDP. However, whilst they can produce some pain relief, do they actually treat the metastatic disease? And there was very little evidence of improvement in survival. So the next phase that came along, and this was in the 2000s really, was the advance with radium-223, which is an alpha-emitting bone-seeking agent. It's an analog of calcium, and it's a calcium mimetic. And we found that radium-223 is quickly taken up into new-forming bone, and therefore has a uptake around about 10 times in the bone around the metastasis than it does in normal bones. And it's the first of these agents that really went through a proper phase 3 randomized controlled trial that had enough patients to see whether or not the patients actually had an improvement in survival. And at that time, 50 kilobecquerels, because obviously it's an alpha, so you don't need very much, was given per kilogram of patient's weight in 6 ejections about 4 weeks apart. And that was compared to best standard of care and a placebo, which was just saline. Obviously, we couldn't image the patients because we weren't allowed to know if they were injected with the radioisotope or not, it being a blinded randomized controlled trial. This trial called Alsimca, the results were published in the New England Journal of Medicine and demonstrated there was an improved survival around about 3 months in patients with castrate-resistant metastatic prostate cancer. And further sub-analysis demonstrated that in almost every single group, there was an improved survival, and that included whether or not they had had previous bisphosphonate treatment, previous chemotherapy treatment, such as taxanes. The only group where there was no significant difference were those with a small number of metastases, less than 6, and presumably because these patients would have a long survival, whatever they do, because they have a low disease load. So it's a fairly universal treatment that could be given to pretty much anybody. This was one of our patients from my previous hospital in Cambridge, and you can see here there are multiple areas of focal uptake throughout the skeleton, which are consistent with multiple bone metastasis. This patient has had taxanes and failed, and so they moved on to radium. And the patient had 6 cycles of radium 4 weeks apart. And the bone scintigraphy at the end of that demonstrates that there's been a good partial response. We haven't cured the patient, but the patient has had a significant reduction in the number of tumor sites. And this was maintained for 3 years after the end of treatment. The patient needed no further anti-tumor medication. So it demonstrates that this can be an effective treatment. Let's move to the other agent that was being developed at that time, and that was metylenzobenzoguanidine, MIBG. And this was an amine, and it had a similar structure to DOPA, and it's taken up by the vesicular monoamine membrane transporter, or VMAT 1 and 2 systems. And we now know this is particularly present in those kind of tumors such as paragangliomas and pheochromocytomas that have decoupled succinate dehydrogenase B and D subunit defects. So the first paper published from the group at the University of Michigan in Ann Arbor was in the JNM in 1981, and they just looked at RD123 label product for imaging, and then further imaging with RD131 label product was also published from the same group in 8 patients with pheochromocytoma in the New England Journal of Medicine. Also, they presented their data a couple of years later of the first 5 patients treated with the higher activity of the RD131 MIBG. And this was as a paper that was published in The Lancet, and a further paper that was published in a medical physics journal, which showed that in the first 5 patients that were treated, 2 of them had a partial response. Now, this image isn't from one of their papers. This is from a more modern patient who's been treated with RD131 MIBG for metastatic pheochromocytoma. This actually comes from the Royal Free Hospital. This treatment is still used and can be very effective, but one of the problems with it was that only a very small number of the molecules that were given were actually radioactive. So in the normal preparations, only about 1% of the molecules were radioactive. So you had to give quite a lot of MIBG to get any kind of therapeutic dose into the patient. And because it itself is an amine, it has a reaction a bit like adrenaline or noradrenaline. So we were limited how much we could give in terms of the radioactivity because of the pharmacological effect of the MIBG. So the solution to this was to produce highly specific MIBG, sometimes called carrier-free. It's not actually carrier-free, but about 50% of the atoms are now of iodine are now radioactive. So this now means that we give much higher activities without the patient having any significant pharmacological effect. So this was a trial that was published in 2019, and in patients who weighed more than 70 kilograms, they were giving 2 fractions of around about 18.5 gigabecquerels, and these were given 90 days apart with a dose reduction for smaller patients. And they treated 68 patients, and half of those had a good response to the treatment, and some were able to stop their medication. However, bone marrow toxicity, as you'd expect, was quite high, but most of these patients were just treated by transfusion or giving GCSF or EPO, and no patients required stem cell transplantation. Now, this may seem a little bit drastic, but this is fairly normal for patients receiving chemotherapy, for example. So within an oncology world, this would be considered to be of manageable toxicity. This is the Kaplan-Meier curve that's published in the JNM, and you can see there was a median overall survival of 36 months in these patients who had very significant disease. Now, malignant pheochromocytomas are quite malignant and fast-growing tumors. So though we don't have a randomized controlled trial, this is at least an interesting result. Hopefully we will have such a randomized controlled trial soon, and this product will become more widely available. At the moment, it's only really available in North America. So when we got into the 1990s, and that's when I came along, radionuclide treatment to some degree went local. And this is an example with RD131 attached to a fatty acid called lepadol, which is actually, when you take the heroin out of the poppy seed oil, it's what's left. And that has been used as a radiological contrast agent, and is particularly taken up with certain tumors such as HCC. You can't inject it intravenously, you have to inject it into the hepatic artery, and is extracted from blood by the HCC. So here you have a colloid scan, shows you how old it is as a colloid scan, with a hole in the liver where there is the HCC. And then this is after being given RD131 therapy. with Lepidol, and you can see the iodine-131 Lepidol is taken up into the tumor. So the tumor matches the hole on the colloid scan. Over time, people are trying to use different isotopes. The iodine-131 Lepidol is very difficult to handle. And there was a significant amount of work done by the Korean National University and Singapore General Hospital in developing a rhenium product, which started off in 2001. And originally, it didn't stick to Lepidol very well. There's quite a lot of free pyrenate, which was passed into the gut. But over time, they improved the chemistry so that it would stay within the Lepidol, and therefore you get a good therapeutic effect. The advantage of using the rhenium generator is that we, with the help of the International Atomic Energy Agency, we're able to reduce the cost of each treatment to around about $100 US. And this is some dosimetry work that was done, showing that the higher the dose that you could deliver to the tumor, more likely you are to have a reasonable response. And certainly you can either make the disease stop growing or to shrink if you could get tumor doses of 75 gray or more. If the dose was less than that, then the tumor continued to grow. And this was published by the IEA in 2008. These days, we tend to move to sonic board yttrium particulates for a similar kind of treatment. The advantage of these is they're much easier to handle. You don't need to manufacture them on site. And there are two forms of these. One of these, which is a resin ball called Spheres, and the other one, which is has the yttrium embedded in glass, and they're called Theraspheres. And the same general technique, these are injected via the hepatic artery, and that infuses the liver. You may give it to the whole liver, or you may give it to a lobe. These days, most of the time, we try and give it to the lobe. And we try to deliver around about 100 gray to the tumor and try to keep the dose to normal liver or to the contralateral liver lobe to around about 30 gray. Yttrium has a much more penetrating beta than the iodine or the rhenium, but it has a shorter half-life. Also, once this stuff sticks into the liver, it doesn't really move, so you don't need to worry too much about systemic toxicity. It has been used both with HCC, but also with colorectal cancer metastasis and uveal melanoma liver metastasis. This is an example of a patient again from my previous hospital in Cambridge, and here you have an FDG PET scan. This is a patient who has a CA colon metastasis in the right lobe of the liver, and you can see the intense uptake of the FDG within the liver metastasis. And then you can see that the second set of images is the yttrium-90 PET scan. There is in fact a small pair production from Y90, which you can pick up with more sensitive modern PET scanners. And you can see here the distribution of the small little dots are the distribution, in this case, of the glass spheres around the tumor. And the reason is you have a luxury blood supply around the edge of the tumor, and this is where the little particles stick, and then they can irradiate both the blood vessels of the tumor, causing it to necrose, and the tumor itself. Recently, there has been some work with a randomized controlled trial using much better dosimetry in terms of treatment planning. And originally, we would give an activity that was related to the patient's weight and the size of the tumor compared to the amount of the size of the liver. But the results were good, but not brilliant. So the Dosophere trial that was published in Lancet Hepatology and Gastroenterology 2 years ago looked at 60 HCC patients. And again, they used a dosimetric approach to ensure that there was over 100 gray to the tumor and less than 40 gray to normal liver. And if you used a sort of calculated dose activity, the response rate was 33% and the adverse event rate was 33%. But using the dosimetric approach, then the response rate was 95% with adverse events down to 20%. So we would now recommend that you use a dosimetric approach. Other approaches of use, for example, P32 silicon, This P32 is quite a soft beta, but it has a long half-life. And if you can detect it so it doesn't move, then you can treat very localized tumors. And particularly, there's an interest in treating pancreatic cancers that are too big to be operated on, but have not yet metastasized. It's a small but significant group of patients. In this case, you give it via EUS, you use a calculation using MR imaging of the volume of the tumor. And again, you try to ensure you give at least 100 gray. And this has recently been approved in Europe and the US. So this is a patient again from Cambridge. You can see here there's a head of pancreatic carcinoma. Before treatment, the SUV max is 5.1. The middle images are just 2 dots, and what those are actually where the P32 is injected. There's a whole body image, and this is to prove that it stays in the site of injection. These 2 images are 1 week apart. And then a 6 weeks later FDG PET scan demonstrates a significant reduction in the size of the active tumor, and also in the uptake, the SUVs dropped to 3.2. Please note there is a pancreatic duct stent placed between the 2, and with that's done just to make sure that in the post-treatment swelling, there was no blockage of the pancreatic duct, the biliary duct. So we move on to from the 1990s to 2000s, and then we get to what we could call more traditional theragnostics, particularly with Eric Krenni's teams in Rotterdam. And with the team in Basel, they worked on the use of first of iodine, but then more specifically indium 111 labeled DCP octreotide. And the first case was published in 1990, but by 1993, we had over 1,000 cases. And this was able to find more than 90% of neuroendocrine tumors, but some of the very aggressive tumors and insulinomas weren't positive. And we now know this is the flip-flop phenomenon where they're either positive with FDG or they're positive with the somatostatin imaging. And since 2010, we've used SPECT-CT to look at this. So for example, this is a SPECT slice, and you've got this, the 2 dots at the bottom of the kidneys, and then you have an area of uptake is that colonic activity. But when you do a SPECT-CT, in fact, you can see that they're not in the colon, it's peritoneal metastasis. So the accuracy of these imaging techniques has been improved by SPECT-CT. And the next agent to come along was a technetium-based product, because indium's not available worldwide, but technetium pretty well is. And this is something called Hynectop, goes under the trade name Tectroid. And here you can see this is a series of patients from my colleague, Professor Chikla in Poland, and you can see multiple sites of uptake in this patient with some lymph node, mesenteric lymph nodes, and some pelvic nodes. And you get very good high quality imaging. And the primary in this case was in the ultimate body of the pancreas. So this is really starting to get as close as we can to PET without using PET. But obviously, we do know that most of the times, if we have it available, we would try and use PET with somatostatin imaging. So this is gallium-68, which was developed in Hanover, Heidelberg, Basel. And this has really, since about 2001, become the standard of care in patients with neuroendocrine tumors in terms of imaging. And one of the earliest papers came from Professor Vergelini's group at Innsbruck, with 84 patients imaged, comparing the 2, and found the sensitivity of the gallium-68 dotatate was 97% compared to 52% with just the octreotide. So a significant advance, and we found that around about 11% of patients that may have appeared negative with the indium or the technetium agent were positive with gallium-68, and therefore it would enable more patients to be treated. Not every country can use the gallium-68. The half-life is very short, it's just about an hour, which makes moving around large countries like the United States difficult. So for them, they have developed a different PET pharmaceutical in the use of copper-64. This has a much longer half-life, about 12 hours, so it can be distributed much more widely. Whether or not it will be used outside of the US, I don't know, but it may be better used in countries which have long distances, and therefore it could be prepared in a central pharmacy and then distributed There are some slight advantages. For example, the uptake in normal liver is much reduced compared to the gallium-68, and therefore it may be easier to see small liver metastasis. So we move on to theragnostics, and when we started off with yttrium-90. And in 1998, Novartis initiated a phase 2 trial of dota-octreotide, but this time with amino acid protection to protect the kidneys, because in early trials, patients developed liver failure because they had radiation toxicity to the kidneys. There was a mixed result from this trial with quite high levels of toxicity, partly because people didn't really understand what amino acids to give. Later on, a different peptide was used, which was based on the dotatate used for imaging, but this time imaged with labeled with Y90. And this showed good efficacy with reduced toxicity. And again, we would have to protect the kidneys with amino acids. And this is, again, a patient supplied by my colleague, Professor Chiklo in Poland. And you can see here a MIP image of a high nictate with multiple liver and upper abdominal metastasis. And below are the two post imaging bremsstrahlin images. You can get bremsstrahlin images from the Y90, showing a reduction in the activity of the liver after the first and the second cycle of treatment. Normally 3 to 4 cycles were given. However, the Y90 does produce problems with toxicity, particularly bone marrow toxicity once you protected the kidneys. So there was a search on for a different therapeutic radionuclide. And that initially led the team in Rotterdam under Eric Krenin and Dwi Kukenboom to look at lutetium-177 dotatate, which became the commercial Lutathera. And this is the first good trial. It's a sort of phase 1/2 trial of 300 patients, showing that as long as the tumor didn't progress, and that only happened in 20% of patients, in 80% of patients there was disease stability or tumor shrinkage, then there was improved survival. So this was showing that you could match the gallium-68 or indium octreotide imaging, and then you had the Lutathera or lutetium-177 therapy. This led to the NETA-1 trial, and this was a trial where 2/3 of the patients received Lutathera in 4 cycles, 8 weeks apart, and 1/3 were given best supportive care, and there was a follow-up period. And what they showed, unfortunately, is slightly pale, but you can see that the dark black line is the progression-free survival of those patients who were given the Lutathera. And even by 2.5 years, there were 50% of them hadn't progressed, whilst in those patients just given best supportive care and high-dose non-radioactive somatostatins, within 7 months, half of them had progressed. So there was a reduction in progression of 82%. And this was achieved without any really significant side effects. This went on to be published again in the New England Journal of Medicine. So Lutathera and PRRT are now established. So what's next? Well, the next step, as we know, is PSMA. So we know that, for example, gallium PSMA has uptake in various different normal tissues, such as the salivary glands, pancreas, small and large bowel, kidneys, and the bladder. But it also has some low-level uptake in inflammatory tissue. But other than that, you have uptake in tumor. Now, it's called prostate-specific membrane antigen, but it's not prostate-specific. There are a number of tumors that can express this antigen, which is related to the folate system, but it is particularly useful in imaging patients with carcinoma of the prostate, because these tumors tend not to have uptake of FDG, while some of the other tumors that you can use PSMA imaging in do have uptake of FDG. Now, it can be very popular. We can be doing up to 10 scans a day in our particular hospital. So very soon after the development of the gallium-68 product, again from Heidelberg and Hanover in Germany, people started to look at a therapeutic approach by using lutetium. And again, the Heidelberg team were a leader with this, and then this was taken up by other groups, such as in Pretoria and also in Bad Berka with Professor Baum. And the use of lutetium-177 for the therapy, again, it has a beta with a 6.7-day half-life, and this allows for post-therapy imaging very nicely, and promising results in early phase 1 and 2 trials. Now, this is actually a patient from one of our phase 3 trials of the early use of this product, and you can see there's the PET study demonstrates a site of focal uptake in the chest. This is actually in the vertebra. And then after the first treatment, you can still see activity there. But by the third treatment, the treatment cycle, there is no uptake, and there's no abnormal uptake anywhere else. This patient has been had a complete metabolic response. And this patient had previously been treated with hormones, but no chemotherapy. So the idea is to position this before chemotherapy. However, other trials have looked at it in patients either instead of chemotherapy or after chemotherapy. So this is an Australian randomized controlled phase 2 trial called therapy. And these patients would have failed first level chemotherapy, such as normal taxane, like docetaxel, and then would be considered for cabataxel as a second-line chemotherapy agent. But in this case, they were either randomized to having the cabataxel or having the lutetium PSMA. There were a couple of things that they did. Is they wanted to have good uptake of the gallium-68 PSMA first, so they needed to have lesions that will have uptake greater than normal liver. And also they were looking for patients who were not FDG avid, because there are only a small number of patients with prostate cancer are FDG avid. If they are, this is a more aggressive disease. So overall, the response rate in terms of tumor reduction of PSMA of more than 50% was 66% for those who received lutetium PSMA and 37% for those who received chemotherapy. And again, adverse events were rarer, 33% for the lutetium and 53% for those on the chemotherapy. Recent updates suggest overall survival was similar for both arms, but we've recently found out that when the trial period finished, any surviving patient who'd been given carbotaxol was then given the lutetium PSMA. So effectively, all the patients ended up on lutetium PSMA. But a phase 2 trial doesn't get you a product license. So for that, you need a phase 3 trial, and this was the VISION trial. And this was a multinational trial in North America, Europe, and Australia in patients who failed 1 to 2 treatment groups of taxanes. Patients had to have all known disease positive on PSMA imaging, and they're either randomized to standard of care, which wasn't defined, it was up to the clinician, or 4 to 6 cycles of PSMA therapy. And again, like NETA-1, 2/3 of the patients received the active treatment. So the median, and this time they're not progression-free survival, but overall survival. And there was an improvement of 4 months in overall survival in those patients who had the lutetium PSMA. So there was a significant improvement in survival, and this has led to this product being approved both in Europe and in North America. So theragnostics is now becoming a very active area. So in 2020, the British Nuclear Society underwent looking at this as how do we actually deliver these services? And we know that there are a lot of research trials. So this is a table from a report that we produced, and that was the number of multi-center randomized trials which are registered with the FDA, or the European Medicines Agency, as of May 2020. You can see there's a whole list of agents, some of them new, some of them old, but in a whole range of cancers. And most of these are phase 2 or 3 trials, which means that if successful, these products will be coming through to the market in the next 3 to 5 years. And in 2020, the US pharmaceutical companies invested $6 billion into radionuclide theragnostics, which gives you an idea of how much is being invested in this new area of treatment. But there are challenges. So for the past 20 years, nuclear medicine has been getting very close to radiology. In some countries, it's almost completely disappeared and just become a sub-area of radiology. And that's because obviously with hybrid imaging. However, there's led to quite a large number of these new specialists who do nuclear medicine being very good at imaging, but they're de-skilled in therapy and clinical care because they haven't been treating patients. So we need to change our training systems so that we ensure that we maintain clinical care. Now, again, in our review of the British Nuclear Medicine Society and other societies and colleges in the UK, we looked at the inequality in the provision of therapy agents. So we picked the most common, which was radium-223, and we looked across the regions and nations in the United Kingdom, and there are 11 regions in England, and then there's the nations of Wales, Scotland, Northern Ireland, and each of them's got a population of about 3 to 5 million. And what you can see here on the graph is that we didn't get any results from Northern Ireland, but the green areas are areas where there was a good delivery of service. The yellow areas was where it's poor, and the red areas was where it's extremely poor. And there's no real difference in the types of patients in these areas. What there is a difference in the ability to deliver a theragnostic service. So there is limited reactor capacity. Since I've done the talk, there's been a real problem in the United States with lutetium-177 PSMA in the fact that no more patients can be treated. They're trying to just preserve the amount that they have. And this is partly because of the lack of targets who primarily come from places like Russia. And the supply chain has been affected by the war in Ukraine. And also COVID and its effect, particularly in China, had resulted in significant reduction in the availability of various things that were required to provide a radionuclide therapy services. So one solution which has been used in the UK and some other countries as well is that there's quite a lot of radioactive waste from nuclear power stations, and this can be mined for therapeutic radioisotopes, particularly some alpha emitters and things like radioactive lead. So there's an active investment program being done by many of these countries now to find new sources of therapeutic radionuclides. But things in medicine never stay still. And what Saul started was a revolution, which resulted in today's theragnostics. But if he was alive today, what would he do? Well, he would be advocating that we should use the new revolution in genetics and how genetics will change medicine, particularly in the way that it moves on to phenomic expression. And so this new science of genetics and phenomics is going to change the way we practice even simple things like the treatment of thyroid cancer. So in 2023, at the beginning of 2003, we were treating the patient. Maybe if they had a micropapillary, then we wouldn't do anything else. But if they didn't, we would look for the histology. If it's thought to be good histology, then we might not want to treat any further. But if it had, at the moment, normally for patients with good histology, we give the patient a ablative dose of radioiodine. If the tumor is small and it doesn't look like it's likely to metastasize, we may only give 1 gigabecquerel or 30 millicuries, and then the patient will be on lifetime thyroxine with thyroglobulin follow-up. If the patient had more aggressive disease, we may give much higher levels, 100 or 150 millicuries, or 3.7 to 5.5 gigabecquerels of iodine-131. And again, the patient will be completely ablated of their thyroid and have lifetime thyroxine and thyroglobulin follow-up. But as we move forwards, maybe things will change, and already this revolution is with us. But over the next decade, we may start to see the way that we treat these patients very differently. So after a diagnosis is made, if they have the first thing we do is we do the microRNA. The microRNA is not the same RNA that's used to code for proteins. These are small, normally 8 to 12 base RNA, which are excreted very specifically by certain tumor types. If the patient doesn't have any evidence of this microRNA and they do a panel of about 18 different types, then it's thought that they're unlikely to have any tumours. These patients may just enter follow-up, and then they get repeated every 6 months. If they do have evidence of microRNA, then we would do a dosimetric scan, possibly with RD131, but now we'd like to do 124 PET. Then the next thing we do is we look for things like BRAF or MAC mutations. Now we know that the BRAF system and various other systems are related to the toxicity of the tumor, its malignancy, and therefore if you have these mutations, particularly the V600E mutation, you're much more likely to lose your NIS gene, and the patient's much more likely to die of metastatic disease. If they do therefore have these mutations, then the patient may go on to a total thyroidectomy, and then they would have a dosimetric, the calculated ablation, but also they would then have tyrosine kinase inhibitors, which will be the correct amount for that particular patient, but then they would need to be put on lifetime thyroxine, and again every 6 months they'll go back to have their microRNA measured. If the patient doesn't have these mutations, then they're unlikely to benefit from the addition of chemotherapy agents. So these patients will go under what we call much more traditional of treatment with thyroidectomy, total thyroidectomy, then the dosimetrically calculated RD131, and they will go on lifetime thyroxine. Again, with every 6 to 12 months, they'd have a microRNA measurement done to see whether or not there is any evidence of recurrence. If you notice, there's no iodine scans in this technique, and there's, except for dosimetric purposes, and there's no thyroglobulin, so we don't have to worry about thyroglobulin antibodies, for example. And also, if we don't have to worry so much about the NIS gene, because we can deal with that by giving the right tyrosine kinase inhibitor. There's a whole group of these now which will become available, which can have activity against thyroid cancer and can actually even the tumor can redevelop the ability to have NIS with some of these drugs like dafiranib, for example, turns a NIS negative to a NIS positive tumor. So there's a whole range of stuff, and I've written about this in a recent article in Seminars in Nuclear Medicine. So theragnostics is the future. I've got here a gallery of people around Saul Hertz's picture. I tried to get representatives from different organizations, different continents. I covered most continents, I think. Clearly, there are many, many more than this. And if I had a screen big enough, then maybe your face will get on here as well, as we all try to deliver the theragnostics of the future. So I thank you very much for listening. Thank you.